Obsessive compulsive disorder. A 19-year-old man is brought to his primary physician by his father, who explains that his son washes his hands 100 times a day, will not touch anything that has been touched by someone else without scrubbing it first, and has a fear of germs that has left him isolated in his bedroom, unable to eat, and wishing he were dead. Although the father reports that his son has always been finicky, this problem started approximately 2 years ago and has gradually become completely disabling. How should this patient be evaluated and treated? The clinical problem. Obsessive compulsive disorder, OCD, is a neuropsychiatric disorder characterized by obsessions or compulsions, or both, that are distressing, time-consuming, or substantially impairing. OCD is the fourth most common psychiatric illness, with a lifetime prevalence of 1 to 3%. The World Health Organization has identified OCD as a leading global cause of non-fatal illness. The hallmark of OCD is the presence of obsessions, compulsions, or both. Obsessions are repetitive and persistent thoughts, such as of contamination, images, such as of violent scenes, or urges, such as to stab someone. Obsessions are intrusive, unwanted thoughts that cause distress or anxiety. The person attempts to ignore or suppress these obsessions with another thought or action, that is, a compulsion. Compulsions, or rituals, are repetitive behaviors such as washing, or mental acts such as counting, that the person feels driven to perform in response to an obsession. Compulsions are meant to neutralize or reduce the person's discomfort or to prevent a dreaded event. Everyone obsesses about some event occasionally. The diagnosis of OCD, however, generally requires that obsessive thoughts occur for more than 1 hour each day. In addition, obsessions related to OCD do not suddenly start and stop with a specific event. Although many people know about obsessions regarding contamination, there are many variations of OCD, and patients often do not realize that certain thoughts they have are consistent with OCD. Most persons with OCD have multiple obsessions and compulsions. Although the themes underlying OCD, for example, abnormal risk assessment, such that the most improbable outcome is considered almost certain, appear to be similar across cultures, cultural factors may influence the content of obsessions. For example, a predominance of aggressive and religious obsessions has been reported in studies conducted in Brazil and Middle Eastern countries. Conclusions and recommendations. The man described in the vignette has a classic case of contamination OCD. He should be questioned regarding other possible obsessions and compulsive behaviors. Assessments regarding his level of insight and the presence of a tic disorder are relevant to assessing prognosis and the choice of therapy. Once the diagnosis is made, the clinician should educate the patient about the nature of the illness, including the low frequency of spontaneous improvement but the high likelihood of responsiveness to therapy. The patient should be informed that exposure and response prevention therapy and pharmacotherapy with an SSRI are considered to be first-line treatments that improve OCD symptoms in a majority of patients. To help the patient choose his treatment, he should be educated regarding the process of exposure therapy and the probable length of treatment, weekly sessions for approximately 16 weeks, followed by some monthly sessions. Similarly, he should be educated regarding medication side effects and told that medication ought to be continued for at least 1 year.